The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Well, good afternoon, everybody. Eric back with you. I want to welcome you back to the FlightBridgeED Podcast and really look forward to the next few podcasts. We've got some cool stuff coming. Today, what we're going to do is a part one of a two-part series on neuro and neurological emergencies. We're going to focus on, a quick glimpse into pathophysiology, and then today we're going to look at epidural bleeds and subdural bleeds and talk about all the different things that we need to be considering when treating these patients. And then part two, if you come back and join us for that, we're going to focus on kind of below that dura mater, so any subarachnoid hemorrhages, parenchymal hemorrhages, intraventricular, intracerebral, and kind of talk about the differences and the different treatment algorithms that we have to focus on based on each one of those. So very, very excited about that. And then I'm actually doing a podcast this evening with a good friend of mine, Kelly Miller. He is a clinical manager for Air Methods and very, very good at cardiology, balloon pump therapy, and things like that. And so we've been trying to plan to get together for a long time. So we're going to be rolling out a kind of an intensive balloon pump question and answer, and hopefully be able to answer all the questions you have with Kelly. So look forward to that here in a couple weeks. As I stated, we are going to start with a little bit of pathophysiology. And so let's jump in and join us for a quick glimpse of the epidural, subdural hematomas. We know that there's a lot of literature right now. There's a lot of focus about traumatic brain injuries, and we know that we really have to be very aware of what's going on with our patients when it comes to traumatic brain injuries. We know that there's a huge mortality increase if we have secondary injuries to our patient. And those secondary injuries are related to either hypoxia or a hypoxic event or any hypotensive event. And we know that we have to have good perfusion and we have to have good oxygenation. So we'll kind of expand on that. So let's really quickly discuss the layers of the brain. And we know that our cranial vault, our cranium, is that outer protective area. Right below that, we have our dura mater, and we know that that dura mater is a very thick, very fibrous material, very, very tough. Below that, we have our subarachnoid membrane. That subarachnoid membrane kind of lines and lays right over the top of the pia mater, which is the very lower part of, or I should say, the very last membrane that covers the actual brain. But that subarachnoid membrane actually covers the brain, and it's got that spiny-like projections based on the contour of the brain. So we know that we have potential spaces in between those areas, and we know that we have a space between the cranial vault or the cranium and the dura mater, and we have a space between that dura mater and the brain surface. So anything subdura or below the dura mater is considered that subdural hematoma. And then if it's below the subarachnoid membrane or that subarachnoid space, we know that that's a subarachnoid hemorrhage. And like I said, we're going to expand on those more in part two. We also have to understand that it's very, very important to maintain a normal ICP. And we have to kind of look at the concept or the terminology that describes Monro-Kelly hypothesis. And if you've taken any critical care classes or you've studied critical care or neurology, you know that the Monro-Kelly hypothesis is essentially saying that we have just the right amount of brain, blood, and cerebral spinal fluid in our cranial vault. That maintains a perfect amount of pressure. And if we have any increase or decrease in one of those, the other one has to kind of pick up the slack. And so when we think about trauma or we think about traumatic brain injury in general, either we have blunt force trauma, we have either an aneurysm, or we have penetrating trauma, but there's something that's added to the mix. And so we have to, consider what is that? And oftentimes we know that that's blood or a penetrating type injury, but blood is that secondary thing that increases. And if that is a closed injury and there's no way for that blood to escape, we know that ICP is going to increase. So we have to always understand that is what maintains our ICP, and we have to understand that ICP increase limits perfusion. We have to, get them to a definitive facility so they can relieve that and lower that ICP. Well, what is our normal ICP? Our normal ICP, based on the different literature that I've read, is, between 0 and 20 millimeters of mercury, 0 to 15. It depends on what you read. And so we have to evaluate ICP kind of from a guessing standpoint. And what I always teach is always estimate on the high end. And so whether you estimate 15 or 20 when you're kind of trying to determine the proper amount of cerebral perfusion pressure that you need, I would always go at least 15, but 20 is not a bad option. Well, why do we want to estimate that? Well, we have to remember that we have to maintain a cerebral perfusion pressure. And cerebral perfusion pressure is the amount of pressure that's needed to perfuse the brain. We as adults need a minimum of 60 for our cerebral perfusion pressure to perfuse our brain, but preferably about 70. So 70 is always kind of that goal. 60 is a great goal for kids, but when you get below 60, when you get into that 50 range, you start having ischemic injury to the brain. So we always want to kind of think about that when we maintain a MAP blood pressure. Now, obviously, now in trauma, we're always focusing on permissive hypotension, and we know that a high blood pressure is not needed, that we need at least a MAP blood pressure of 60, 65, again, based on the literature that you read, to perfuse everything, our kidneys, our liver, our brain. But when you have a patient that now has a traumatic brain injury, we have to increase that MAP blood pressure. Why? Well, to calculate or evaluate a cerebral perfusion pressure, you have to have two things. You have to have a MAP blood pressure, and then you have to subtract the ICP. As I stated, we have no way of identifying an ICP, so we have to just guess. And so let's just say, for purposes of this teaching, that we're going to say 20 is going to be our guess, right? 0 to 20 is going to be that normal range. So if we had to maintain a MAP of 60 in a normal patient without a traumatic brain injury, and we have to maintain at least a cerebral perfusion pressure of 70, if MAP minus ICP is your cerebral perfusion pressure, that means that for a patient that has a traumatic brain injury, we have no way of identifying true ICP totals. We would at least have to have a MAP blood pressure of 90. So 90 for our MAP minus ICP of 20 equals 70, and that is our cerebral perfusion pressure. So that's minimum for an adult. So if you have a multi-systems trauma patient that's got, multiple fractures, potential chest injuries, potential spleen and liver, so they've got bleeding, this really causes some issues because we don't want to increase the blood pressure to a point where we're going to increase that bleeding. That's the whole physiology behind permissive hypotension. But we still have to maintain a MAP blood pressure that now perfuses the brain. And so that kind of is a fine line. Like I said, any hypoxic event or any hypotensive event that causes a decreased perfusion or a decreased amount of oxygenation in the brain, that increases mortality by 50%. So 50% by having a hypoxic event, just one hypoxic event, 50% by having a hypotensive event. So we really have to watch this, and we have to immediately be aggressive on this and make sure we have a proper cerebral perfusion pressure. So what this means is that even in a trauma patient, if you are unable to maintain a MAP blood pressure that will achieve a cerebral perfusion pressure of 70, you've got to start a pressor on these patients. And I know that, there's a lot of arguments and I think a lot of misunderstandings of why would I start a pressor on a trauma patient? We got to fill the tank. Well, because in this situation, we have to be able to perfuse that brain. And, we know that it's kind of hit or miss. We don't know if this patient's going to survive or not, depending on how bad the traumatic brain injury is. But we have to do our part as clinicians and make sure that we're perfusing that brain and maintaining a MAP blood pressure. So if you're unable to do that because of issues with other injuries, and you're not getting a proper cerebral perfusion pressure that optimizes cerebral perfusion and oxygenation, you've got to start a pressor, and Levophed would be a great choice in that circumstance. So what other ways can we actually limit or hopefully attempt to decrease ICP? Well, remember our role of chemical regulation is driven off of CO2. And, if you've come to our review classes, I really preach CO2. There's so many things that CO2 does in our body. It regulates our pH. It fluctuates a lot of different things. It's a product of normal cellular function, cellular metabolism. It's a function of anaerobic metabolism. So we see CO2 in a lot of different circumstances, but we know that in a patient with a traumatic brain injury, we can keep our CO2 levels on the low side, lower than normal. We know that compensatory range is 35 to 45, and we've all been taught that, keeping that end-tidal CO2 between that 30 and 35 really helps with cerebral vasoconstriction. It actually will, limit the edema in the brain. So we don't want to cause so much vasoconstriction in the brain cerebrally to cause an infarct, but we want to try to limit that. And that's kind of the reason why we do that. In contrast, if you have a hypercapnic patient, so a patient that has a high amount of CO2, we know that causes a vasodilation. And so you're going to have a bigger amount of blood flow to the brain. So that's kind of the thought process on why we want to keep that on the low end. So when we think about secondary injuries, like I said, secondary injuries are caused by obviously the situation, but if providers maybe are not aggressive enough with airway, they're not aggressive enough with blood pressure control or optimizing blood pressure with a pressor early, those secondary injuries are that hypotension or that hypoxic event. So we really have to be aware of those secondary issues. So that kind of goes back to, you're never wrong for intubating a patient that's got a traumatic brain injury. And I've talked about this a lot in other podcasts that, even a patient that has a GCS that's higher than 8, maybe it's 10, maybe it's 12, and we're, unsure of their mentation. We're unsure of are they going to go unresponsive? Remember, they're on a backboard usually. They're going to be strapped to a gurney. Whether you're in the back of an ambulance or you're in a helicopter or fixed wing, it's very important to be able to maintain that airway. And even the ER, if you're an ER nurse listening or a physician listening, you know that a lot of times it's just safer to intubate these patients and secure their airway and optimize oxygenation in the right way. And what I always tell, providers that I work with or teach is, a lot of times we can look at decisions on why did somebody get intubated in the field. And I think we can always armchair quarterback different situations. But I think based on my experience and my experience with different medical directors and different physicians that I've talked to, I think it's always best to err on the side of caution. And I think it's best to secure their airway so you don't have a sentinel event. You don't have an issue where they're on a backboard, they're on a gurney, and you're in the back of an aircraft and your airway is not protected and they vomit. It's very, very difficult to get out of your seat, to unstrap them, turn the board, and clear their airway in a rapid enough manner where you're not going to have aspiration. Remember, aspiration also increases mortality significantly up to 50%. So, there's a lot of little things to kind of consider. And what I always say is, their airway may be perfectly patent. They may be able to talk to you. They may be repetitive in their questioning. But if you ever have a concern, intubate them, secure their airway. And if the ER, when you get there, the trauma center wants to extubate them, then let them do that. But it's always better in our environment to make sure that airway is protected. So when we kind of do that, we want to watch our patients. We want to maintain that end-tidal CO2. And so if you chose not to intubate your patients, maybe it's early on. We still need to look at that end-tidal CO2 and identify, and so using that quantitative nasal cannula, identifying, are they a little bit tachypnic? What's going on with their CO2? Is their CO2 high? Is their respiratory effort actually decreasing? Is their CO2 increasing? That could be a kind of a bad sign. So whether you have them intubated or they're not quite intubated, monitoring end-tidal CO2 is an important aspect. So what are some signs that we have to look at as far as ICP increases? Well, ICP increases are something that a lot of times what I've found, you don't really notice it, right? You may see it in level of consciousness. You may see it with pupillary response, changes like that. But, if it's a traumatic brain injury to where it's just a sudden thing, obviously we're on scene very, very quickly, and we see patients all the time that have either decorticate posturing or decerebral posturing. So those are very poor clinical signs when you see that. That means ICP is already increased to a point where you're having this issue. They've got a pretty bad traumatic brain injury. And we know that if you have a decerebral posturing patient, that's a big clinical sign for a pontine or midbrain brainstem type of an injury. So when we think about ICP, what are some clinical findings? And we always kind of focus on Cushing's triad. And Cushing's triad is something that is a late sign. And I've actually only seen this in the field one time in 24 years. So it's not something I've seen very, very much, but I saw it in a patient that was in a motor vehicle accident. It was a 16-year-old female. It was a very, very sad situation. Deer ran out in front of her, and she was partially ejected. And by the time we actually RSI'd her, got on scene, she was already showing clinical signs of Cushing's triad. She was already bradycardic, had the widening pulse pressure with associated hypertension. So when you look at Cushing's triad, there's a few things we have to remember. Cushing's triad is all about hypertension and widening pulse pressures. You're going to have Cheyne-Stokes respirations. So prior to intubation, these patients are going to have Cheyne-Stokes respirations. But the big difference between just normal ICP and Cushing's triad is instead of having tachycardia with normal ICP, Cushing's triad is bradycardia. So that's where you kind of move from standard ICP to now you're herniating. This patient is herniating, and it's compressing on all those respiratory and cardiac areas in your brain, right? In your medulla, in your midbrain. And so it starts affecting the heart, and you start having bradycardic issues. So that's the big difference between ICP and Cushing's triad, are those two kind of clinical findings. If you do see this, right, if there's any way that we can elevate the head 15 to 30 degrees, I think that's always a great option. Oftentimes in a trauma situation, we're unable to do that because of backboards. And I know that there's a lot of listeners out there that actually are working in systems now where you're not boarding patients, you're using soft collars and things like that, and I think that's great. I'm not working in an area like that. We're still boarding patients. Any patient that's going to a trauma center, you're going to board. But we need to try to do that. So if you have a stroke patient, if you have an aneurysm type patient, if you can elevate those patients, that's a big, big deal. Always limit noise, limit light, limit suctioning, limit anything that can increase ICP even more. And as I've said many, many times on podcasts, one of the biggest issues with increased ICP is secondary to pain and pain response. So that's where using fentanyl. Fentanyl is a great medication. You're not going to have blood pressure fluctuations with that. And so utilize your fentanyl, and remember the pain management aspect is an important thing. Even though they're comatose or maybe they're altered to a point where they're not responding to you, they still feel pain, and that ICP increase can increase even further with increased pain. We always want to obviously look at temperature control, make sure our patients are covered. Even in the summertime, remember that patients can become hypothermic in ambient temperatures in Iraq and Afghanistan of 130 degrees. So, these places I've gone to where, you have no blanket in the aircraft, or, argument of, well, it's summertime, we don't need that. That's hogwash. Read the studies. It's important that we understand that the trauma triad of death starts by us not taking care of our patients' temperature and temperature regulation. And then again, we need to always consider, good pain management and sedation. I can't stress that enough. So when we look at the different types of head trauma, we have to understand that there's multiple diagnoses. And like I said, I didn't want to kind of flood you with a whole bunch of them. I want to focus on the first two. So we're going to do subdural first, and then we're going to look at epidural. And then in part two, we're going to look at actually everything below the subarachnoid area. What I'm also going to do is I'm going to write a blog post, and I'm going to put this blog post on the website. You'll have to go to FlightBridgeED.com, click on the blog. I will post CT scans and descriptions of each one so you can kind of look at that and identify what I'm talking about. So the first one we're going to look at is a subdural hematoma. And remember, this means that this is below the dura mater. And so oftentimes subdural bleeds are either traumatic in nature, and a lot of times they're traumatic in nature, but they also can be based on a hypertensive hemorrhage or aneurysm. So based on the presentation, a subdural bleed can manifest very, very slowly. I just read a clinical study, or I should say a case study, where a gentleman, it actually manifested over almost 3 months, where a gentleman actually stood up and hit his head on something at his house, and it slowly started to bleed, but it was such a small bleed that he didn't have clinical findings or symptoms, I should say, for almost 3 months. So this can be very, very slow, or it can come on very rapidly. Oftentimes, when we're dealing with our patients, these are obviously rapid findings, and so patients can actually go unresponsive immediately in these situations. The important thing to know about subdural bleeds is that they're very highly fatal. 40 to 60% of patients that have subdural bleeds actually will die from that. And there's also a very high incidence of diffuse axonal injury associated with these subdural bleeds. So remember, really quickly, diffuse axonal injury most often are going to be normal as far as a CT scan goes. But the important thing to know is that CT scans are not very diagnostic for diffuse axonal injuries. They're only about 12% diagnostic. So 88% of the time it's going to miss a diffuse axonal injury. So usually a diffuse axonal injury will be kind of a situation where the patient doesn't respond normally, has all the clinical signs of a traumatic brain injury, but their CT scan is normal. They're not showing anything else. There's no subdural bleeds. There's no subarachnoid. There's no epidural bleeds. They're just showing every sign of a traumatic brain injury. CT scan, like I said, is often normal 88% of the time. So the diagnostic imaging needs to be an MRI, and MRIs are 92% accurate in diagnosing these diffuse axonal injuries. So if we come back to the subdural focus, again, advanced airway management is a must in this situation. You need to be aggressive with your traumatic brain injuries. You've got to take control of that airway immediately. We want to obviously treat them appropriately with our pain management. We want to, utilize the right medications in RSI. If you have a patient that is already hypertensive, they're tachycardic, they're showing clinical signs of ICP, then ketamine probably would not be the best induction agent to use in that situation. That means they've got to be hypertensive or tachycardic, because we remember ketamine is an amazing medication. It's cerebral protective, but it's not the best medication in that setting because it will cause an increase in blood pressure and heart rate. So in that situation, I would use etomidate. But if their blood pressure was appropriate and you were worried about the etomidate dropping the pressure at all, then ketamine is absolutely perfect for this type of patient. We always want to adequately resuscitate this patient, airway-wise, oxygenation-wise, put them on the ventilator, optimize those things. And I think that's kind of our key when we're providing care for these patients in transport, is just to make sure that they're properly oxygenated, that we're perfusing that brain as best as possible, and we're evaluating our MAP blood pressure, and we're identifying MAP blood pressure based on traumatic brain injury, not permissive hypotension of 60 to 65. So remember, we have to guess on that ICP. That ICP norm is 0 to 20, so we don't know. It could be 40. So we have to have a minimum on those patients of 90. So, that's kind of going to be your goal is that. When you start looking at what this treatment algorithm does in the hospital setting, if you transfer these patients, most hospitals, from what I'm seeing, are getting away from mannitol. They're getting away from mannitol because of kind of those secondary issues. It's kind of hard to deal with. Not everybody carries it. Not everybody's familiar with using it. But the big reason why we give mannitol is because of that osmotic diuresis. So we have to remember that the whole point of that is to try to reduce the amount of fluid or volume in the cells in our brain. And so instead of using mannitol, we're actually seeing a lot of hospitals use 3% normal saline, actually 3% all the way up to 23.4% normal saline. And they'll give 5 to 10 mils per kilo boluses, and they'll try to get that sodium at about 155. And we know that sodium norm is, 140, 145. So they try to keep that sodium a little bit higher. So remember, that's a hyperosmolar shift. It causes the fluid in the cell to be pulled outside the cell to actually go to the solutes. And so that's kind of the goal. Pull the fluid from the cell, reduce the amount of volume in the cell. That's going to reduce edema, reduce swelling. The other thing they're going to do is, based on that, they're going to look at a serum osmolality. And what they're doing there is they're trying to keep that below 320. And we know that 320, I think the range is around 270 to 320-ish. Forgive me if I'm off a few points. But the whole goal is to try to keep that on the high end. The higher the number, the less amount of fluid is in the cell. So that means that there's more solutes in the cell. The cell is drier. So that's kind of a tool that we use to identify how cellularly hydrated somebody is. So the goal is to keep them cellularly dehydrated to try to reduce that edema. And then in really severe cases, they'll actually put patients in a barbiturate coma. But there's a few things to kind of talk about that. And I learned this from a nurse practitioner that was doing kind of an internship in a level 1 ICU. It was kind of a neuro ICU. And what he said is that these neurosurgeons really have to talk to the patient's family, because once they start this patient on a barbiturate coma, if there's any clinical sign that this patient's probably not going to survive very much longer, they have to, talk to the patient's family, because once they start them on that barbiturate coma, it takes 30 days from the day of where they stop giving the barbiturates for them to actually be able to do a brain death determination. So they can't do any brain death determinations if the patient's family wish to, terminate efforts for 30 days after that last dose of barbiturates, which is usually, phenobarbital. So that's always something that they talk to the family about, just to kind of give them that decision. Like I said, I'm going to put a CT scan on the actual blog site. So if you want to listen to this podcast and look at this blog, you'll kind of see what I'm talking about. So the first CT scan that you're looking at is you're looking at a subdural bleed, and you'll see that there's a blue arrow, and the blue arrow is pointing to this white area. And you'll see that white area is very wavy. And so that's one of the kind of the clinical diagnostic tools you can use to differentiate a subdural bleed versus an epidural bleed, is watching or looking at that blood go over the contours of the brain. Very, very different when you look at an epidural CT scan, and we'll kind of talk about that. The other big long arrow that you're going to see is an arrow, or I should say, if you look at the very center of the CT scan, you'll see that middle area, and you'll see it shifted to the right. That area shouldn't be shifted. And so when you see that shift past midline like that, that's called a subfalcine herniation, right? That's shifted over. And you can see that the ventricles are shifted over as well. When we look at the next CT scan, we can see that the CT scan is also a subdural bleed. But if you notice, the black area on the right-hand side of the CT scan is actually very black or dark in comparison to the first CT scan that I showed you. So that first CT scan with the white area, that white area showing blood, that means that this subdural bleed is a very new bleed. It's within the last few hours. When you look at a CT scan like this, it's subdural, and you see that black area, that blood is now that black, that means that subdural bleed is old. It's hours to possibly days. And so you can identify very quickly how new of a injury this is, or if this is an older injury that's kind of slowly progressed. So to kind of recap, remember that subdural bleeds are very, very often fatal, 40 to 60%. Be very aggressive with your airway management. Be very aggressive with keeping that end-tidal CO2 between that 30 and 35 range. If you have a patient that's being transferred and they already have a diagnosis of subdural bleed, I highly recommend that you go and look at that CT scan. Make sure it's a true subdural bleed. Make sure that it wasn't misread. I've had that happen a few times where I've looked at CT scans that they've been diagnosed as a subdural bleed and they were actually epidural bleed. And that can really change how we treat our patients. So now let's look at an epidural bleed in contrast and kind of look at the differences and why it's important to be able to identify and differentiate between the two. Epidural bleeds are very, very common, but they're very, very survivable. Almost a zero mortality rate if they're identified and treated in a timely manner. Now let's look at an epidural bleed. Epidural bleeds are bleeds, remember, that are between the cranium and the dura mater, so that blood is trapped in between that dura mater and the actual bony prominence or the bone, the cranium. They're very highly survivable, and so almost a zero mortality rate if it's treated appropriately and recognized appropriately and treated in a timely manner. 70 to 80% of epidural bleeds are actually secondary to some type of an impact to the temporal area of the brain. So any temporal impact to that area on either side actually is a prime cause of epidural hematomas. That's called the terion region. And essentially that's the region where the frontal, the temporal, and the parietal bones kind of intersect into a point. So that's kind of a really weak area. And the meningeal artery lies right underneath that. And so when somebody takes an impact right there, with that meningeal artery that lies right below there, obviously there's a laceration, and that bleeding starts and starts building up in between that dura mater and that cranium. Very important, though, to identify this if you have the ability to, and there's a couple clinical things that you can kind of trigger on based on somebody's report or maybe a first responder that's on scene or a witness to the accident. So initially, there's going to be a temporary loss of consciousness when they have this impact or they hit their head. They're actually then going to gain responsiveness. They're going to be lucid. They may or may not be able to answer all questions appropriately, but they're going to be with it enough to be conscious. And then once this bleeding in the brain between that dura mater and that cranium starts getting greater and greater, and that ICP increases, you're going to start having a patient that has another loss of consciousness. And that's why this is very, very important to identify, because if the patient's airway is not maintained with an ET tube and secured, if it's at that point where they're lucid and they're just about to lose consciousness again, there's a very high probability that you're going to have issues with that airway. They can become clenched. They can have trismus. You can have vomiting. So you can have some major airway issues. And so it's always taught to intervene with that airway every single time. No matter if their GCS is 14, you need to take that airway until that blood can be drained off in between that dura mater and that cranium. And so very, very big deal. Oftentimes they're going to go into a seizure. You don't want to have this issue and be trying to maintain this airway or establish that airway. So it's always best to, again, be proactive and not reactive and kind of get behind the game. So advanced airway management is a very, very important part of treating these epidural bleeds. So as I said, the CT scan on an epidural bleed is much different. And it always reminds me of looking at a pupil. And so if you think about this, dura mater is a very thick membrane. The blood actually causes a tenting of that membrane, and it pushes and obviously shifts the brain but it pushes and there's no contour of the brain seen. So it looks like a perfect symmetrical, like half circle. And so that's how you identify the epidural bleed over the subdural bleed. Remember, the subdural bleed is going to be that wavy. It's going to take the form of the brain because it's lying right on top of that subarachnoid area. So take a minute if you're at a hospital. If they give you the opportunity to, or you have the opportunity to go check a CT scan, they should be able to pull that up very, very quickly and take the time and look at it. And again, it's kind of saved my butt a few times where we actually intervened with the airway based just on the CT scan and the clinical findings where we may not have. So hopefully this was a kind of a good glimpse into two really important parts of neurology when we look at subdurals versus epidurals. Like I said, we are going to jump into part 2. We're going to look at subarachnoids. We're going to look at interventricular, intracerebral, what a parenchymal hemorrhage means, what extra axial bleeding means or intraaxial bleeding means, some kind of different terminology, and talk about the different treatment algorithms. Very, very important. I think part 2 is even more important than part 1 as far as our treatments go. So, like I always say, thank you so much for all the following, for all the great emails, for just all the kind words. We know that we're nothing without you. And until next time, we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.